Okay, we're going to talk about the immune system today. The immune system has several functions. It protects your body from pathogens on the outside of your body, but it also protects your body from internal threats. Outside your body pathogens, those would be your viruses and bacteria that are out in the world, and your skin is there as a barrier to protect your body from these pathogens. The minute there is an opening in your skin, it immediately causes you to be compromised because now that's one of your barriers to protect you. Protects the body from internal threats. Well, that could be that certain cells didn't replicate properly and now they're floating around, possibly going to cause havoc, such as cancer. Cancer is literally just a defect of the immune system. Pretty much all of us have some cells floating around our bodies that could be cancer cells right now, but your immune system is going to identify them and it's going to attack it and it's going to kill it. When your immune system is not working the way it should, it doesn't do that, and that's why basically cancer, the tumor grows from these cells that are damaged. They don't die after a certain amount of time. Each cell has a limited number of days. I know red blood cells, I think, is 120 days. After 120 days, they self-destruct. Well, if that mechanism isn't in the cell and it doesn't tell it to self-destruct, then it will just keep replicating and replicating and replicating, and there you go, there's your tumor. But that's the immune system is what controls that. Your immune system is the one that says, hey, this isn't right, let's get it, let's kill it. So that's what it means when it says by removing dead or damaged cells. Your immune response, you have your T lymphocytes, your B lymphocytes. For the most part, your T lymphocytes are made in your thymus, which is in the middle of your chest, kind of underneath your breastbone. Now, your thymus is large as a child, so it's just cranking out these T lymphocytes left and right. And as you get older, your thymus shrinks. By the time you're elderly, you really don't have much of a thymus left at all. And this is why a lot of elderly people have some immunity issues, because their thymus, they're not putting out any T lymphocytes. Now, the B lymphocytes are made in the bone marrow. Those are made throughout your body. But basically this is your army. That's what's there. Their whole purpose is sit back and watch for anything that's not supposed to be there. And they go after it and they attack it. With the T cells, you have different kinds. You have the helper cells, the suppressor cells, and the cytotoxic cells. You have different kinds of immune responses. You have your humoral response, that's an immediate, and it protects you very rapidly. And then you have a cellular response, which is a little bit more delayed, but it protects you against the slower developing bacterial infections. It's also involved in the autoimmune response, allergic reactions, and also the rejection of foreign cells. The T cell count, that is actually what's used to determine if an HIV positive patient, if they're now an AIDS patient. Now the T cell count looks at basically the immunity. That could even be with cancer patients. They look at that, but typically a T cell count's between 500 and 1600, and as long as the T cell count is above 500, the immune system is healthy. The immunocompromised state begins when T cells drop down to 200 to 400. If a T cell drops below 200 with an HIV positive patient, that is when they are given the diagnosis of AIDS. So there's different types of immunity. You have innate immunity. That's what you're born with. That is your immunity that you have the day you are born. You also have acquired immunity. This is immunity that you can receive passively from your mother's antibodies when you're first born, or the mother's milk. Also, it can be your immunity that that you develop or your body makes in response to an infection. So it kind of breaks down into subcategories, but active immunity is like a natural immunity, but it's from being exposed to the actual disease and you've built up antibodies against it, or for vaccinations. If you get a vaccination, that's what stimulates your active immunity. It's basically stimulating those antibodies to be made to fight that antigen that's in your body. Hypersensitivity and allergies, those are basically your immune system just being overactive. It's just overly sensitive. So basically it's an abnormal response to certain substances that trigger an exaggerated reaction. That's why they are individualized. What one person may be allergic to, someone else is not. Some allergies, the reaction doesn't occur until the second or subsequent contact with the allergen. You hear that often with people with bee stings. First time they were stung by a bee, there was no problem. But then the second time they were stung by a bee, they could have an anaphylactic reaction. And that's because when they were stung by the bee the first time, the body has built up some antibodies against it and could potentially, like I said, be hypersensitive and be overly aggressive to the point where it would cause an anaphylactic reaction. It could just cause an allergic reaction in general. Typically bee stings, you see anaphylactic reactions. With an allergy, with assessment, you want to look at their signs and symptoms, which is like itching or tearing or burning of the eyes. They could have nasal stuffiness, skin rashes. Skin rashes, you see that a lot with poison ivy, right? And poison ivy is one of those that maybe when you're a kid, you're playing in poison ivy, you don't really don't have a problem. But then when you're exposed to it again, you will have a reaction or a rash because now your body has built up those antibodies and recognizes it and goes after it. Interventions with allergies, you want to identify the allergen and then you want to manage the symptoms with antihistamines, anti-inflammatory agents, or corticosteroids. Now think about it. Allergies, what makes your nose run and your eyes water, that's histamine. That's a histamine response. What makes you itch, your skin itching, that's histamine. So you take an antihistamine to reduce the histamine in your body. For allergic reactions like contact dermatitis, you can use ointments and creams or a soothing bath. Anaphylaxis, I mentioned it a minute ago, that is the overreaction to the point where the throat swells up. The minute, if you have somebody that's having allergic reaction and they start saying, oh, my lips are tingling and getting numb, oh, now my tongue feels like it's tingling, you need to take action right now, because if it's affecting their mouth like that, it's only a matter of seconds probably before it starts affecting their throat and it will close their airway. So they need, hopefully, if they'll have an EpiPen on them and they need to get that epinephrine injected pretty quick. Some other allergies that as healthcare workers that we may see are latex allergies. A lot of healthcare workers don't have a problem at all with latex gloves, but as they continue to wear them and continue to work, over time they'll start developing a reaction. And that's just from the constant exposure. It's thought that it's from the proteins that's actually in the natural rubber latex. And symptoms can be very mild, to just having like a rash, like if it's a glove, rash on your hands, or it can even be more severe, conjunctivitis, rhinitis, or even anaphylactic. So you should always have available latex-free supplies to care for your patients. You need to make sure patients, you ask them if they have a latex allergy. So you should make sure that You've got the latex-free supplies, but you also keep in mind that some medications are kept in containers that have latex. So the best thing possible if someone has a latex allergy is to use medications from glass ampules. So we have the autoimmune disease. This is literally autoimmune. Auto means self in medical terminology. So this means that it's basically immune system is attacking itself. That again is an oversensitivity, hypersensitivity to the point where your body doesn't even recognize things that are itself. Some of the more common, because there's a lot of different autoimmune disorders. The ones that I have listed here, well, we've got lupus, systemic lupus erythematosus. We've got scleroderma. We see that. The next two are not as common. I put them in here because they're in your book, but they're not that common. Lupus is a chronic, progressive, systemic inflammatory disease that can cause major organs and systems to fail. Basically, connective tissue and fibrin deposits. They collect in the blood vessels, and that causes necrosis and inflammation of the blood vessels, lymph nodes, GI tract. There's no cure for this, but remission is possible. The classic sign of lupus is the butterfly rash on the face. They'll have weakness, fatigue, weight loss, photosensitivity, joint pain. Again, there is no cure. All we can do is support them, including help them with nutrition, skin integrity, and of course monitor their BUN and creatinine levels. Renal impairment is often one of the first things to go. Your kidneys they're very temperamental. If you're going to start having perfusion issues, usually the first place you see it is the kidneys. So that's always when you're monitoring the BUN and creatinine, that gives you an idea that the person is being perfused well, because the minute they stop peeing, you need to start worrying. Medication that's used quite often is hydroxychloroquine, which I know y'all are familiar with that just even from COVID. It's an anti-malarial drug, but it does affect the immune system and can help decrease the risk of the lupus flare-ups. Now, scleroderma, that's a chronic connective tissue disease. It's similar to lupus because it's got the inflammation and fibrosis and sclerosis. It affects the connective tissue throughout the whole body, the skin, esophagus, heart, GI tract. Again, you want to direct your treatment towards going into remission. You can't cure it. So you think about, effects even like the GI tract. So you would want to encourage the person to eat small, frequent meals. You want to make sure that they're hydrated. They can use steroid creams. Basically, the skin, it will start hardening. Not just the skin, but anything that it affects. But you see it with the skin a lot. The next one is polyarteritis nodosa. And I have never seen this. Basically, it says it's a collagen disorder, and systemic vasculitis causes inflammation in the vessels, and it says prognosis is poor. And then the last one is pemphigus, a rare disease, occurs predominantly between middle and old age, causes unknown, and disorder is fatal. Again, I have never seen this, but look at the signs and symptoms. The person's very fragile. They've got partial thickness lesions that bleed, weep, and form crust. And this gets me. They'll have Nikolsky's sign, which is separation of the epidermis caused by rubbing the skin. So that doesn't sound very pleasant now, does it? All right. We also have Goodpasture's syndrome. Now this is an autoimmune against the glomerular basement membrane and alveolar basement membrane. It's mostly the lungs and kidneys affected. It is most common in males or young adults that smoke. They're not really sure why this happens. And it's usually not diagnosed until there's been significant damage already done to the lungs or kidneys. Some of the signs and symptoms of good pastures are shortness of breath, hemoptysis, which y'all know what that is, right? If you don't, look it up. Decreased urine output, edema, weight gain, hypertension, tachycardia. Interventions, again, are suppression of the autoimmune system using either corticosteroids or plasmapheresis. Plasmapheresis, we talked about that with like myasthenia gravis and Guillain-Barré, where it's almost like a dialysis machine where it goes through and runs your blood through this machine, and it'll usually pulls out the plasma, because that's where these antibodies hang out. So it pulls out this plasma. Now your body will remake plasma, so don't worry, but it'll help basically just lessen the amount of antibodies, because that's what's attacking your body. So you want to try to get some of those out of your system. Lyme disease. Lyme disease it's caused by the spirochete, I don't know if I'm saying that right, Borrelia burgdorferi. And basically it's a bacteria that's acquired by a tick bite. The first word, spirochete, that just describes the shape. It basically means spiral shaped. So it's a spiral shaped bacteria. Other shapes, things like we remember Streptococcus, Staphylococcus. Well, coccus just means spherical or round or oval. And then you also have bacilli, like there's certain Bacillus cereus. I'm not real familiar with these, but bacilli just means rod shape. So some of these words just describe the shape of the bacteria. But if you're bit by a tick with this particular bacteria, it causes an autoimmune response. There's different stages of this. The first stage can occur, anywhere from several days to months following the bite. The classic sign is a bullseye rash, but not everyone gets the bullseye rash. And you don't necessarily get the bullseye rash where you were bit. You could have the tick bite on your head, and you can get the bullseye rash on your leg. Flu-like symptoms, fatigue. Then you can go to the second stage. That can again occur several weeks after the bite. That's where you start developing joint pain, neurological complications, cardiac complications. And then the third stage is where large joints become involved and arthritis progresses. Here's a picture of the bullseye rash, and it looks like a bullseye, doesn't it? All right, Kaposi sarcoma. Now, Kaposi sarcoma, these are skin lesions that you will typically see with people with compromised immune systems. You see it a lot with AIDS patients. It's a slow-growing tumor. It appears as a raised, oblong, purplish, reddish-brown lesion. Basically, interventions are chemotherapy or radiation. Again, this is very commonly seen in HIV patients, but it can happen to anyone that has a compromised immune system. And there's a lot of opportunistic infections, which basically means they're out there. These infections are out and about, and it could be something even in your body. The cells that are not that are damaged, that are not right. But your body, our bodies, our immune systems fight all day long. And there's a lot of things that we're exposed to that we don't get because of our immune systems. Now, if your immune system's compromised, you can very easily, these bacteria, viruses, you can very easily get. And unfortunately, even with AIDS patients, people don't die from AIDS. They die from the opportunistic infection that they got because their immune system was so compromised. You see pneumonia a lot. A lot of AIDS people die from pneumonia. Here's a picture of Kaposi's sarcoma. That's what it looks like. I've seen patients with this before, and they were AIDS patients. All right. Post-transplantation immunodeficiency. That's a big word, isn't it? Um, this is an immunodeficiency or immunosuppression caused by therapeutic agents. That's when people have a organ transplant that's coming from something other than self. So your body's going to go after it and try to destroy it. Well, obviously, if they've had a heart transplant or a liver transplant, you don't want the body to destroy it. So you have to give them, a lot of people say, oh, anti-rejection medications. That's basically an immunosuppression agent. So you need to give them this immunosuppressant, suppresses the immune system so that the body doesn't attack that organ or tissue. They're going to have to take it for the rest of their lives. The minute they don't take it, then their body's probably going to reject that organ. Interventions for something like this, you would want to make sure you teach the patient that they need to be very careful, that they are immunosuppressed. So they need to wear a mask if possible. They need to make sure they wash their hands and use hand sanitizer. They need to stay out of large crowds, or if, like be around sick children, they don't want to do that. Signs of rejection, it depends really depending upon what kind of organ or tissue is transplanted, but typical signs is basically the patient's not going to feel very well. They might have pain or swelling in the area of the organ. They get fever, flu-like symptoms that include chills and body aches, nausea, coughing, and shortness of breath. All right, we're going to talk about different immune system medications. First thing is the big one. It's HIV and AIDS. It used to be HIV was a death sentence. When it was first discovered, no one really knew what it was. They didn't know how to treat it. And, if you got HIV, you basically, you had a death sentence hanging over your head. Think about like Freddie Mercury, the lead singer of Queen. I mean, he died from HIV. But then on the flip side, you got Magic Johnson, the basketball player, who's been living with AIDS for, I think, at least 15 years or more. So what's the difference? Why did one person die so quickly and one person has been living with it? Well, it has to do with the medications. Now, back, like I said, when AIDS, HIV first came out, first was discovered, they didn't know how to treat it, so they didn't have these medications. These medications were developed pretty quick. People used to have to take like a cocktail of pills where they had to take just handfuls of pills like every 4 hours around the clock. I mean, even getting up in the middle of the night and take their medicine. They could not miss a dose at all. But fortunately, it has been narrowed down where they've been able to combine a lot of the drugs in that so that they don't have to, it's not as labor intensive as it used to be. But it's basically called heart treatment. And if you ever have HIV patients, you'll hear them say, that they're, on the heart treatment. And that basically stands for highly active antiretroviral therapy. So you have different medications that are under the heart treatment. You have NRTIs, NNRTIs, PIs, infusion inhibitors. Now, each one of these different classes of medication work a little differently. Some of them will keep the virus from replicating. Some of them will I'm trying to think of what the other one does I'm looking for. I can't find it. Anyway, basically they'll keep the virus from replicating. They don't kill it. They can't get rid of it. It's a virus, so you're going to have it forever. What it does is these medications will help keep it from multiplying. And that's why people, with HIV, they look at their T cell, they look at their viral load, and often you'll hear, oh, their viral load was undetectable, which, does that mean that they don't have HIV anymore? No, they still have HIV. It's just undetectable. And that's what, if they're complying with taking their medications, that's what we want. That's what we want to see. Usually if people, become non-compliant, then their viral load will start increasing again. And unfortunately, that's when people, medications make people feel like crap, and medications are expensive. So they go, oh, I'm feeling pretty good. I think I can go without this today. And they start getting more lax. And then next thing boom, now they've got AIDS. Now, if they have AIDS and they can start taking their medication again, they can basically increase their T cell count. They're still going to be called an AIDS patient, because once you're an AIDS patient, you're an AIDS patient. But you are now basically, you can increase your T cell count. So these different medications, like I said, they work in different ways. The ultimate goal is you're not going to cure this disease, but you want to either delay or even reverse the loss of their immune function. You want to preserve their health, and you want to prolong their life. You want to always keep an eye on your HIV patients, on their labs, because again, they are at high risk for the development of opportunistic infections. So you need to watch, especially their white blood cell count and their H&H. They can become anemic very quickly. The white blood cell count, you want to take a look at that. So always remember to check your labs, and especially those two. NRTI, one of the medications with that is didanosine. And one of the, a pretty nasty complication with that is pancreatitis. So if you've got a patient taking that, you need to watch their serum amylase levels. If it increases 1.5 to 2 times, it could be fatal. So you need to keep an eye on that. And if you do see that, then you need to discontinue that medication. In an RTI, one of the examples is nevirapine. I don't know how to say that. Complications could be osteoporosis or liver disease. I'll take osteoporosis over the pancreas going bad any day. Protease inhibitors, Indenovar, Sequinovar. The complications include GI problems. Metabolic issues are the most serious complication of that medication. You have fusion inhibitors, atazanavir. Now, that's the one probably most of y'all have heard about. It's called ATZ. That used to be the medication that was one of the first medications, was ATZ. I think I mentioned before, like if you ever saw the musical Rent, one of the songs even talks about taking their ATZ. ATZ, there we go. That's the one I was trying to think of. I said before the other ones would prevent the HIV cell, the virus from replicating. This one actually blocks the entry of HIV into the CD4 cells. I was trying to remember that, and I couldn't think of it. Side effects: nausea, diarrhea, fatigue, and pneumonia. Medications need to be taken on their regular schedule. Patients have got to be educated. They can't miss their medicine. They have got to take it. They can't miss it and then double it up, take a double dose. They've got to take their medication. They've got to be very, very vigilant about that. Some other immunosuppressants. We've got basically, this is what they give to the transplant recipients to help prevent their rejection of their organ. And also to treat the autoimmune disorders that we talked about a few minutes ago, like lupus. So we've got some examples there. One of them, the cyclosporine, that one is the most common. You see that a lot. Big thing about cyclosporine that you need to be aware of is it is nephrotoxic. So you need to closely monitor their BUN and creatinine levels. Anytime you've got somebody on an immunosuppressant, you need to be watching them for any signs of infection, because we've basically wiped out their immune system. So we need to keep an eye on it to make sure that we're there to help support them if they do become ill. Antimicrobials. We also call them antibiotics. Different antibiotics work many different ways. There's different classes. Here's a list of a lot of the different classes, and I just did one example of each. I tried to use the most common one, like penicillins. We've got amoxicillin, or tetracycline is doxycycline. But if you're interested in seeing more, you can look at page 846 in your book, and there's a chart that lists all of the different classes and the drugs, examples of the drugs. All right, practice question. The nurse is assisting with planning the care of a client with a diagnosis of immunodeficiency. The nurse would incorporate which intervention as a priority in the plan of care? Protecting the client from infection, or providing emotional support to decrease fear, encouraging discussion about lifestyle changes, or identifying factors that decrease the immune function. So this is a priority question. What do we need to think about when we have a question that talks about priorities? You need to think about your Maslow's hierarchy. So looking at these different answers here and thinking about Maslow's, which one's at the bottom, at the base? It's certainly not emotional support or talking about their lifestyle changes. It's protecting them from infection, right? That's down there at the bottom of Maslow's. So that's how you would answer that question. So the answer is number 1. All right, well, this concludes the lecture on immune system. Any questions? Let me know.